So I'm really happy to be here. I spoke at the Tallahassee version of the Parkinson support group, and I really enjoyed that. And that's when I met Dr. Malady, and think that I would love to have her as my doctor. So what I wanted to do is actually kind of a springboard from what Congressman Yoho just said in terms of positivity. So I'm a geriatrician. I look around and I see that a lot of you could potentially be my patients. Although some of you look like you're maybe in the 60 to 70 or so age group, which to me is pediatrics. But what I wanted to do was kind of frame the science around the things that Congressman Yoho just said. That is, I was in Maine, actually, earlier this week giving a talk, and one of the geriatricians there said, you know, I sat down and I computed how much time a patient spends with me over a year's time period. And as you know, older people go to doctors a lot more frequently than younger people do, so there's a fair amount of business of a person's life when they're older and have different maladies. But he said, I counted it all out, and it's 0.1% of the time that person has contact with the medical field. The amount of time, I mean, everybody remembers it so much because often it's hard, it's stressful, and it's expensive. But it's actually a very small amount of time in one's life when you consider it. So what happens all the rest of the time? Life. And what can be done in life to have as good a life as possible. One of the things in geriatrics that drew me to geriatrics was the concept that most of the things that we have as we get older, we can't cure anymore. We have to learn to deal with them, to try and treat them as effectively as possible, to prevent complications, hopefully to forestall death. All of those things are our goals. But the quality of life is what people tend to focus on the most. In an interesting study where they asked 100-year-old people, what do you fear the most? The fear of death wasn't even in the top 10. It was all quality of life issues, not being able to do the things I want to do, having to be too dependent on other people. Those sorts of things were what they said were their greatest fears. So the focus I want to take is on life and not necessarily on disease. So basically this is kind of the outline. I want to talk about this idea of person-centered care. It's getting a lot of attention now, which is great. Congress passed laws that are pushing the idea of a patient-centered medical home. Other aspects of the National Institutes of Health are really talking about person-centered care. It's great to have that being talked about instead of disease-centered care. As I mentioned, I'll talk about quality of life. I wanted to get to some interesting research that proves that mom's advice was right. And then end with a subject that's often not addressed, but I think very important. Some people call it end-of-life care. Personally, I call it controlling your destiny. You being in control of the choices that are made. So, what exactly is person-centered care? IOM stands for Institute of Medicine, and that's their definition is it's care that is respectful of and responsive to individual patient preferences, needs, and values. And the key word in there is values. From a medical perspective, we are trained to treat things according to what the best science shows is beneficial. But that doesn't necessarily mean that that thing that we're advising you exactly fits your values. You're the one who has to determine whether the treatment fits your values. And so every discussion with the doctor is not only what is the right medicine to take or the right surgery to have, but will this medicine help you fill your values and meet your values? ARC stands for the Agency for Health, Research, and Quality. And it says patients must become active participants in their own care and receive services designed to focus on their individual needs and preferences. And there again is that word preferences. There are many times that I see a patient And as I said, the average age of my patient is 82. And I'll say, well, now, why are you taking this medication? I'm thinking, what disease was diagnosed for which it was given? And they say, well, because the doctor told me to. Well, in my mind, that's not good enough. Yes, you want advice from a doctor. That's why you pay them. But the reason that you take the medicine should be because you value the outcome of taking that medicine. I had a patient yesterday. I said, now, why do you take this high blood pressure medicine? And they looked completely quizzical and said, for high blood pressure. I said, well, why do you want to take medicine for high blood pressure? And she couldn't come up with an answer. And she had never put the two and two together, that the reason she was taking a blood pressure medicine was not to get her blood pressure down. It was to not have a stroke or a heart attack, which is what blood pressure causes if left alone for a long time. But until she really understood that, the only worry she had was, what's my number? And when you're in that kind of a mind frame, it doesn't give you any way to think about, how can I be in control of my own destiny? Because she has a lot of other ways that she could lower her risk of a stroke or a heart attack than just taking a medicine. But she needed to make sure, I needed to make sure that she valued the goal of not having a heart attack or a stroke. So there is something that you might have heard called evidence-based medicine. And I wanted to put this picture up because there's a part of it that is often lost, unfortunately, in our medical practice. Yes, the top says best research, and that's really where we ought to be getting our information. And that's why what Congressman Yoho said is so important, that we have the research going on to find out what is the best evidence of the treatment for this condition. But notice there's two other important parts to evidence. One is, what is the clinical experience that the people treating you have? They have a lot of experience with individuals. Research is done on a large population of people, and you may or may not have been involved in that research. But even if you were involved in that research, it doesn't necessarily mean that the general outcome of the research fits you personally. That has to be a personal decision. And that personal decision has to be guided by your values. So patient values, when I was a medical student at University of Southern California, I had a mentor who said, if you really listen to the patient, they'll tell you what's wrong with them. And if you really listen, they'll tell you how to get them well. And that was really focusing in on the values of the patient. Obviously, if the patient does not value that treatment, they're not going to take it. And frankly, one of the things I like about taking care of older people is they actually still respect physicians. Young people don't anymore. But I do have patients who say, yes, doctor, and then go off and do something completely different. That's because they're afraid to talk to me about not valuing what I'm recommending. I'd much rather know from the patient whether they value that recommendation and whether it fits their values, because then they'll follow the treatment. But if they don't value it, we know it's not going to get done. So I have a kind of extremist approach to patient-centered care. I think that really the way our health system ought to be oriented is that patients get exactly what they need and want, exactly when they need and want it. Those aren't my words, those are Don Berwick's words, the former head of Medicare and Medicaid, CMS. He is the quality guru of America and has pushed how do we improve quality in American medicine for over 50 years. And I think those words are very poignant. He says we ought to host patients in our health, that we ought to, instead of hosting patients in our healthcare system, we ought to be the guest in their healthcare system. They ought to be the ones driving the healthcare. He thinks that every medical decision is based on informed consent, and I'll describe that a little bit more. And a personal saying I have is, no one knows best because we all know differently. What's good for this patient is often exactly wrong for that patient, even though they have the same disease. And so that's why this relationship with the doctor is so important, so you can get to the heart of the matter of, is this the right decision of treatment for me? given my values. So this is really what informed consent. There was an interesting study done back in the 70s when this was first being talked about, where they asked doctors, what is informed consent? And they said it was making sure you get the patient to sign the form before you do the surgery. But informed consent is much more than that. You have a right, because you pay for it, to get a recommendation for the doctor. But in that recommendation should be what the benefit of that recommendation is and what the risk of following that recommendation is. But you also have a right to know what the alternative treatments are and the risk and benefits of that. And what's likely to happen if nothing is done, if no medication or surgery is done. So this is truly informed consent. Then you'll have had all the cards laid on the table, and you can pick the hand that you want to play. So this is now a little bit of research around quality of life that comes from Brian Kemp and a wonderful book he wrote in 2012 called Quality of Life. And Brian was my partner in crime at USC for 11 years when I ran the geriatric rehabilitation service at Rancho Los Amigos Medical Center, which is one of the USC teaching hospitals and the largest rehab hospital in the world. And we had a geriatric rehab service, and Brian is a psychologist, and we were both what was called co-chiefs of the gerontology service. And Brian now has a very rare progressive neurologic disease where he is in a motorized wheelchair with a ventilator to breathe him, and he drives it with his tongue because he's lost control of all of his body. And he says his quality of life is great. It's amazing. Now, what he's done is research on over 30,000 people with disabilities about how they perceive quality of life. And what's interesting is that it is inherently subjective. One person with the exact same condition and disability may say their quality of life sucks, and the other person says it's great. The other thing is, it's not related to the objective evidence that the person has. Now, we use objective evidence. I'm not saying we shouldn't. As geriatricians, we use objective evidence of a person's thinking, for instance. We measure how they think as a way of diagnosing Alzheimer's disease, for instance. And we use measurements like that to follow someone over time. And I'm a very strong advocate of objective measurements. But we can't automatically assume that someone who is low on a scale is also low on quality of life. So what they did, they asked themselves, how do you rate your own quality of life? Terrible, very bad, bad, neutral, good, very good, or great. You can see it's a +3 scale for great and a -3 scale for terrible. And they just would ask them, where do you fit on this scale? And I'd ask yourself that. Where do you see yourself fitting right now? This can change every day, obviously, but where would you put yourself on this scale? Now, the key thing is, why do people put themselves in these different categories? This is a subjective measurement. And what they found was in their research was that it's related to the experience people were having. On the balance, if people were having generally more positive experiences, again, subjectively what they consider to be a positive experience, they tended to rate themselves on the positive end of the scale. And if they were having relatively more negative than positive, they tended to rate themselves towards the negative side, the terrible side. But these were the kinds of positive experience. So in this research, they asked them to describe, they actually kept records on a daily basis of positive and negative experience they had every single day. And they were things like pleasure, success, a sense of purpose. I think that we've kind of heard that from Congressman Yoho too. But the major negative ones were things like physical pain or other types of physical symptoms, psychological stresses, and very importantly, interpersonal, interrelationship kinds of issues. So this was what I thought was the most interesting. So these were people who, on the balance, in each of the categories at the top, said that their overall perspective was from terrible to great. Overall, over the last week, they gave themselves, when they summed up each day, the numbers that led out to this number up there. But look at the number of positive and negative experiences on a daily basis they were having. So a person who rated their quality of life as terrible was having 7% positive experiences on a daily basis versus 93% negative. But the key thing I want to point out is that even at neutral, there were still more negative than positives. But as you see, there's a pretty big flip when a person goes from neutral into any one of the positive areas. It flips almost exactly, 39 from 39.61, positive to negative, to 61.39 on just going up into the 1. So the big thing is changing those positive experiences, trying to increase the number of positive experiences so that the sense of quality of life can improve. And what they found was only a small number or percentage of positive experiences often led to great gains in quality of life. So as you see, when you up into 1, 2, and 3, there's not a whole big difference between the number of positive experiences. So how can you move yourself up the scale? Well, one is to start looking for those things that were found to lead to positive quality of life. What can you do to increase the pleasure in your life? What can you do to increase a sense of success? In some respects, I think that maybe all three of these, but probably especially, I'd ask the artist whether pleasure and success is something that kind of drives you. I know we have at Tallahassee Senior Center, which is the sister ship for the Latro Senior Center. They have a tremendous art program there too. And the times I've gone there and visited with the seniors who are doing the painting, you can see that they are having fun and they love to put their art up in shows and in conferences like this. It's that feeling of success and that great feeling of pleasure that they get by creation of art. On the negative side, what can be done then to decrease the negative experiences, like improving your physical status? And so, obviously in Parkinson's, being on the right medication regimen, but also being active in physical kinds of activities, and I'll talk about that, are all ways of increasing the physical side of positive experiences. Psychological part, obviously there's a lot that can be done in terms of talking with people, possibly medications, but especially what's been shown over and over, I don't know if you know this, but even in a situation that is serious, called major depression, that talking therapy and exercise is just as effective in the treatment of major depression as medications are. And then finally, the interpersonal aspect, and that's where I really agree with Congressman Yoho's points about the importance of being in a support group and the importance of being in a situation where you're working with other people, and also the importance of volunteerism. So, I want to move into something that I think is sometimes more difficult to deal with, which is the realities around the changes that occur in us with any type of chronic condition. I just spent a year in Washington as what's called a Health and Aging Policy Fellow. And this was a grant that I had to be able to study health policy, and I worked with the Senate Special Committee on Aging. And there's really where I think there can be some changes made in medical care, that we need to have policies that are much more directed towards the realities of the medical conditions we have. I am all for searching for a cure for Alzheimer's, a cure for Parkinson's, and that's important research that we should be pursuing aggressively. However, we have hundreds and hundreds of thousands of people with Alzheimer's and Parkinson's and other progressive neurologic conditions where there isn't going to be a cure in their lifetime. This is not going to happen in 5 years. And they need 5 years of improving the quality of care right now. And that's where the policy changes can make a difference. So this is where my focus is much more on what can be done today to increase someone's abilities to remain functionally independent and cognitively intact. So when we look at Parkinson's as an example, we know it causes problems with movement and mobility. So what do I need to be thinking about in advance, in anticipatorily, to be able to prepare for those things? And that's where we might think about house changes. What needs to change in our house that will enable us to be as active as possible so we can do the things that we like, so we can have those positive, pleasurable experiences. The interesting thing about this is those changes are actually good for everybody, not just for the person with Parkinson's. I've been working with the Department of Transportation about what do we need to do to change the way our streets are designed so that older drivers drive more safely. And I always remind people that Gainesville and Tallahassee are two of the most dangerous places in Florida to drive, not because of older people, but because of college students. They are much worse at driving than older people are. But they get better when we change the driving situation for older people. And the DOT is really working hard on this because we have 325,000 Floridians above the age of 85 who are still driving. So we need to make these changes now. We can't wait 10 years to do that because there's going to be twice as many of the 85-year-olds by that time. The other aspect is what devices might be helpful in remaining more independent. And well, I'm very happy. I mean, when I started off in geriatrics in 1980, you'd have to go to a special supply store to get even like a reacher or a walker or anything else like that. Now, they're much more available. However, I would say one caveat is just because they're available doesn't mean that you should just go out and buy them. That's where a relationship with a team, especially maybe a physical therapist or occupational therapist, can be so helpful because many times the device is not appropriate or it isn't used in the right way. Driving is becoming a very big topic in general, and this is a new kind of thought that is happening in geriatrics with regard to driving. One problem we have here in Florida is we have very little public transportation. So the alternatives that are available are limited. But there are some interesting new systems developing. And I'm not sure whether Letcher County has started yet, but there is this system called ITN, Independent Transportation Network. And what this is a group of older people, retirees, usually the younger side of retiring, who drive other older people around when they need it, and they bank basically vouchers or bucks, driving bucks, that then when they get older and have to stop driving, they can use those to pay for the driving, so there's no cost to them. So I think we're going to come up with very new ways of thinking about how do we deal with the driving issue, because really, just like we think about retirement for work, we all, not just because we have Parkinson's, but just because as we get older, there does come a time where it's more difficult to drive for most people, that we ought to think about drivers' retirement. So what's our retirement plan for driving? Do we have one, like most of us have for work retirement? And then, overall, what do we need to do on a daily basis to think about how do I start replacing negative experiences with more positive ones? I know in Brian's study, what they did was they just had people keep their own log. Positive on one side of the page, negative on the other side. And then each day they would look at their log and say, this seems like too many negatives on one side. What could I be doing to move that negative, to erase that negative and move it over into a positive side? So this was what I mentioned about mom's advice. This was a study that was done by Tom Perles, who is a geriatrician at Boston University, and he has studied more 100-year-olds than anybody else in the world has. He has the aging centenarian study going. And he follows people starting at age 100. Just imagine you enroll the patient when they turn 100, and then follows them for whatever number of years after that they live. And what he's found is that there are certain common activities that all of these 100-year-olds have. Eating good food. Have you heard of the Mediterranean diet? We just had a talk about this at the Continuing Care Retirement Center where I have my practice yesterday about the Mediterranean diet. And it's basically a very simple diet. It's eating lots of fruits and vegetables, using olive oil instead of butter, having more fish and less red meats, and wine. So that basic diet, just moving things towards more fresh fruits and vegetables, less butter, less breads, less high fructose syrups and other types of sugars, has a significant impact. There's now been multiple randomized trials. That's where you randomly assign people to the Mediterranean diet versus the usual diet, and many big, what's called meta-analysis, where you put a bunch of studies together and analyze them that show the benefits of the Mediterranean diet. Getting enough sleep. As we get older, sometimes the amount of sleep goes down, but often sleep disturbances occur. So making sure that if people are not sleeping, that it's investigated to find out if there's a problem, and then trying to set life up. There's many things that can be done. You can talk to your doctor about it to improve the quality of sleep that are short of taking a medicine. Drinking water. So I see so many water bottles at all the tables here, which is a really important thing. As we get older, the proportion of fat to water in our body goes down, so that we have less water and more fat. And so drinking water is a really basic, important part. So we know this physiologically through many studies now, but it's interesting that the older persons have just found this through their own living. All things in moderation. The interesting thing is you find people who do things that we might consider to be absolutely wrong in health. For instance, take the biggest one, smoking. Well, have you ever heard of Jean Calment? She is the person, you should know her name, because she is the longest living person ever. She lived 122 years, 165 days. And she lived in France. And she did stop smoking when she was 108. And she stopped riding her bicycle when she was 110. The smoking part was, she only smoked about 2 cigarettes a day, but she did it for 108 years. The funny thing about her was, in Paris, houses are so hard to find that young people will actually go up to old people on the street and say, can I have your apartment, I should have said apartments, can I have your apartment when you die or move to a nursing home, because it's so hard to find one. And what I'll do is enter into a contract with you where I'll pay your rent until you die or move to a nursing home. And someone did this with her when she was 73. And he ended up dying himself, and his contract said that his estate had to pay for her, so she got paid for housing for over 40 years. So all things in moderation. Another important one is stress management. I'm going to teach you a very simple but highly researched and full of evidence stress management technique. But it's not the only one. There are many different ways to deal with stress. And again, I want to emphasize something Congressman Yoho said is, we can't do a lot about the things that stress us, but we can do a lot about how we respond to that stress. And so I'll show you that technique. And then finish on exercise, because this actually is probably the single most important intervention that a person can do. I say that Ponce de Leon did discover the fountain of youth because he walked all over looking for it. It was the exercise that he was doing. Whoops. Let's see, maybe I could get some help on setting this up. Get back to the one that shows stress management, 3-step, but I'll teach you it while you're doing it. So what we know from the medical research on stress is that there are multiple ways to help manage stress. As I said, we can't always control the things that stress us, but we can manage the way our bodies react to it. When we are exposed to stress, in the old days, when we were out hunting for our food, we would be very stressed facing a panther or a bear or something. But then we would get the bear and we'd be ready to eat it, and the village would be happy and everybody would be celebrating and the stress would all be gone. Fight or flight. You have that immediate stress, it's over with. Nowadays, we have stress each day, all day, a little bit, there's a little bit less, then it's a little bit more, constant stress. So we don't even know that we're having a response. But those same chemicals that were created for us through evolution to deal with stress of fighting the tiger are percolating through our body. Adrenaline, cortisol, other types of hormones that start to affect our body in negative ways. So the only way that we can really cut down that kind of stress is to start to change the body's response to stress. So you can do this through something called mindfulness. You can do it through meditation. You can do it through prayer. And you can do it through this technique called heart math, which is the technique that we're using and researching at FSU. So heart math is a very simple intervention. The word heart math is kind of a weird term. It just actually comes because when you go through the formal training for heart math, you actually utilize a little earlobe sensor that detects your heart rate, and you can use that as biofeedback to know when you're getting into that state of low stress. But it's these 3 steps, and if you want to look up more, you can go to the website heartmath.org. So what you do is, you want to sit down or lie down and be in a quiet environment where you're not going to get interrupted for about 5 minutes or so. And you first want to focus your attention on your heart. And then what you do is you start breathing in a very regular, soft way. Not real deep breath, but just nice, soft breathing. But as you're doing that, you're imagining the breath going into your heart. And then what's really interesting in the studies that do this, and this is how that's the same as mindfulness and the same as meditation. But what they've done is they've looked at what they call neurocardiology, the amount of neurologic impulses that go from the heart to the brain instead of the other way around. And there are 39 different little nerve areas called ganglia in the heart that send information to the brain. And so what they found is that if at that 3rd level you try and feel a positive emotion, and again we come back to that word positive, that if you're trying to feel a positive emotion, and interestingly the emotions of gratefulness or appreciation appear to be the most strongly positive, that then it causes your heart to go into this state where it is in a very, it's called high variability, high heart rate variability, that lowers the stress hormones. So you focus the attention on your heart, you start breathing in a very gentle, rhythmic way, with the idea going that the breath is going into the heart, and then you try and feel the positive emotion. Ideally, you actually feel the emotion. You don't just remember having that emotional state. What is helpful in the beginning, when you're learning how to do it, is to remember a very positive emotional state. For me, when I first started the training years ago, the first image that came into my mind was when my son was about 1.5 years old, and I'd lie on the floor and he would just lie and fall asleep on my chest. And it was just such a positive feeling that as soon as I pictured that picture of Gabriel lying there, I could feel that emotion inside me. So it's heart focus, heart breathing, heart emotion. And what's been shown in the research on this is done for about 5 minutes a day, that it will definitely lead to long-term positive outcomes. This is also a great way to change the way you think about something. Have you ever noticed how sometimes you think about something as being really, really negative, and then you think about it a bit more and you go, well, that really wasn't so bad. That's changing a positive experience into a negative experience into a positive experience without the experience actually even changing. It's changing your perception of it. And this is a great way to do it, because what has been shown is that when you're in that state of high heart rate variability, your cognitive work is more efficient, your thinking is more efficient. And so you can reevaluate something and decide to think about it differently. So I mentioned about exercise and the fountain of age. There are many ways that people can exercise. The ideal would be that if a person was doing some type of physical activity, I know you're having another talk on that, so I won't get too deeply into it, but some type of physical activity for 150 minutes a week. It can be broken up, although it appears that probably somewhere longer than 11 minutes at a time is better. It doesn't have to be running or jogging, it can be just simple walking. Any type of exercise is beneficial. And the interesting thing is, there's a great YouTube video, by the way, called 23 and a half hours. If you use YouTube, just go to YouTube and put in 23 and a half hours. And it was done by a physician from Canada, and he has a really simple statement. If you could get all your sitting and sleeping done in 23 and a half hours, could you afford 30 minutes to exercise? So I think that you would see amazing benefits by increasing the amount of physical activity that you have. It really is the fountain of youth. Here's Helen Zeckmeister. She's 82 years old there, and she is doing a deadlift of 245 pounds. And one time she had to compete in a men's 35 and older age group because there were no women her age to compete against, and she won. This is from a book called Growing Old is Not for Sissies, and it's a great picture of senior athletes. I want to give you some amazing data on fitness. So these are slides that come from this physician named Stephen Blair up at University of South Carolina, who's been doing studies of exercise with people for about 30 years, over 80,000 patients. And it's a little complicated, so I'll walk you through it. So this is the relative risk of having a bad thing happen to you. Higher means higher risk of bad things happening to you, mostly heart and stroke kinds of things. The red group are people who are fit, and the yellow group are people who are not fit. Fitness in his test was measured through a complex measurement process called VO2 max. But his study has equilibrated fitness measured that way with 150 minutes a week. So if someone is in the fit group, it means they do 150 minutes a week or more of exercise. So here we have normal weight, overweight, and obese. And you can see obese people who are not fit, the yellow bar, have a very high risk of dying from a heart attack or a stroke. But look at the red bar. Obese people who are fit have a lower death rate than normal weight people who are not fit. Weight isn't what causes their death. It's lack of fitness is what's causing the death. This is a little more complicated, but again, when you see the data, you're going to be amazed. So this is cardiovascular disease incidence, or how many cardiovascular problems does someone have, does this group have? And it's looking at people who have blood pressure problems, but it's controlled, well controlled with medications. Stage 1, meaning even though they're taking medicines, it's not controlled, but it's in the moderate range. And they have severe high blood pressures, that last 3. And look at the high, so fitness is red, low fitness is red, yellow is moderate, green fitness is high fitness. High fitness people in the severe uncontrolled blood pressure have a lower death rate than controlled blood pressure, but not fit. These people, if they go to the doctor's going to say, you're doing great, your blood pressure's under control, keep taking the medicine. But if the doctor doesn't say, how's your exercise going? Are you getting 150 minutes a week? These people are going to die almost twice as fast as the people who aren't taking medicines or aren't under control. In other words, fitness trumps blood pressure as a risk factor for heart disease. And this says it all. These are causes of heart deaths, and we look at all the known risk factors: being obese, being a smoker, having high blood pressure, having high cholesterol, having diabetes. Men and women is red and yellow. And you can see that low cardiorespiratory fitness is at least twice as high as almost every other thing besides high blood pressure. So fitness is really the underlying disease. The same person that makes it 23 and a half hours calls it sitting disease. We could do so much in our country if we were able to increase people's fitness. In fact, you've all heard the talk about smoking, and you know that it's bad. But the reality is only about 20% of people smoke, and 70% of Americans don't exercise. So from a public health standpoint, the lack of exercise is a much bigger problem than smoking is. And what do we know from the science about exercise and Parkinson's? Actually, there's a lot of good data now about its benefit. That number one is, if Parkinson's is in your family, it may prevent the development of Parkinson's, if you don't already have it. Two is that if you do have it, it slows the progression. Three is that fitness doesn't take away Parkinson's, obviously, but it will enhance the walking speed and distance. And that's not a small issue. If people can have a little bit more walking speed, that may be the difference between distance. It may be the difference between staying in their home or assisted living or having to go to a nursing home. It enhances balance, and we all know how common falls are with Parkinson's. And in the studies, it improves the most important thing, in my mind, quality of life. So the last one is just this concept of controlling your destiny. There are many, many, many things that we can do for you and to you near the end of your life. So in geriatrics, the question is not what can we do, it's what should we do. What does the person want? What do their values say? And you can't judge a book by its cover. I've had many patients who say, I want everything done as long as possible. And I've had other people who say, look, I just want to be in my home. I don't want all those medical contraptions. Don't put me through all that. And they have exactly the same diseases and the same disabilities. So you have to ask the person. You also have to talk with your loved ones about it. Every prominent case, Terry Schiavo and others, came because people had not talked to each other about it beforehand. And they were trying to guess, or worse, use their own values to guide the discussion. We really need to be talking about this more. Death is a normal part of life. In the old days, it used to be so normal that the wake was in our own front room, that children were around it, and we all just knew it. But now it's been removed, so it often is in hospitals or nursing homes, and it's away from the rest of other people. People don't get to learn about it. Ellen Goodman, the famous author, started a project with Dr. Berman to try and get people talking, called the Conversations Project. The other thing that can be helpful is to complete an advance directive. I particularly like the 5 wishes document because it's got a lot of other things on it besides medical things. And as I said, quality of life doesn't really come that much from the medical side. And then the other is to ask yourself, is there a fate worse than death to you personally? And to make sure that whoever you appoint as your surrogate knows that fact. This is a really important thing that they know in advance. There's a great website called gowish.org, and on that website there are wishes that one can turn over and say, this is important to me, this is not important to me. You can pick out your top 10 wishes and then tell your surrogate about those wishes. And the last part is the work for the surrogate. It's not enough just to name a surrogate for it. You can't just say, oh, my husband's going to be the surrogate, or my daughter's going to be the surrogate. You have to talk to that person. And you also have to choose a surrogate who you know will follow your wishes. Don't choose someone, as I always say, Don't choose a surrogate who can't live without you. If you have any ideas about holding back on some medical treatments. But a big thing I'd like to see people doing in general is that older people in our society would take on the responsibility to teach younger people about the importance of having open, easy discussions about this. I don't know if you've had it here, but all around the country, we've had 3 now in Tallahassee, is this thing called death cafes. It sounds pretty morbid, but it's really interesting. We reserve a restaurant. People are invited to come, they buy dinner, and they sit around and they talk about death. And surprisingly, there's lots of laughing, there's lots of ahas. It's really an amazing experience when people kind of let down their guard and just start talking about it. So that's kind of the overview. I think we're right at the time for a break.
So grateful Dr. Brummel-Smith made the trip to come speak with us. It's really important to think for, even if you don't have Parkinson's, whatever life throws you, living well with whatever you have. So I think it's a great message.